Okay, so the ventricles are filled with cerebrospinal fluid, or CSF, and that CSF is produced continuously from a specialized secretory tissue within the walls of most of the ventricular system in the brain, and that is, of course, called the choroid plexus. So the choroid plexus, we'll talk about it in a minute. But first, backing up, let's talk about the roles of CSF, which is actually on this slide. So the CSF, the fluid on this in the inside of the brain, provides some physical protection to the brain, so it provides structural support. Of course, the brain itself is floating in a subarachnoid space filled with CSF, but it's produced internally. So there's an internal fluid-filled component to the brain and an outer fluid-filled sort of vault. It's an important transport system, so the CSF moves a variety of ions around the brain. And it's also important in immune surveillance. So immune cells can access and ride around in the CSF. So it's an important transport system for the immune system as well. This is a section of the choroid plexus, and so what you're going to see sort of as a theme is in what choroid plexus is an outcropping poking out into the ventricles, into the ventricular space, and it's ependymal cells in very close association with loops of brain capillaries, and that is what makes up the CSF. So keep that in your mind, and we're going to look closer at that structure. So the choroid plexus, as I said, is that structural arrangement of epithelial cells and capillaries. And these poke out in little poofs into the ventricular system, and they make up this glomus, or pile of sort of frilly looking stuff. And this stuff is, the choroid plexus is the stuff. It's rarely preserved in dissection, so you don't normally see a fixed brain full with a ventricular system full of choroid plexus. It usually gets lost in the fixative as you store the brain in the lab. It's there when you first cut the brain open. The word ependymal just means neuroepithelial. So these are specialized epithelial cells. They just happen to be found in the CNS. And so the choroid plexus follows this the C shape of the lateral ventricles, but it's a bit more limited in its extent. So there's typically no choroid plexus in the anterior or posterior horn of the lateral ventricles, and there's also none in the cerebral aqueduct, which makes sense because the aqueduct is so small and narrow. So typically it's not found there. If it grows into the cerebral aqueduct, it can cause an occlusion with accompanying hydrocephalus. If we look at the transmission electron micrograph level, and this is in a young baby, probably, and an adult, you can see the development of the choroid plexus. And so the apical, or CSF facing surface, is studded in small cilia to propel the CSF along, and slightly less small microvilli, so that there's outcroppings to increase surface area, and that's typically for secretion. What else do I want to point out about this? You can see, so this is the super up close view of one of these. So this is obviously a drawing, and you can see that this outcropping of choroid plexus is ependymal cells surrounding a loop of brain capillary, and that is exactly what you see here. So this is a brain capillary caught in cross section. The blood vessels, BV, is a capillary. The little dark nucleus inside is a red blood cell. It's not a nucleus, sorry. It happens to have no nucleus. So I'll start again. The dark little guy here is a single red blood cell, and it's traveling through a BV, a blood vessel, a brain capillary, and on the outside are the neuroepithelial cells. And together, this complex is choroid plexus. Now, the choroidal capillaries that dive in here from the subarachnoid space, they dive into the choroid plexus, and a couple of things happen. The first is that they're fenestrated while within the choroid plexus. And so that means that substances, including ions, but certainly fluid, can escape from choroidal capillaries for CSF production. And the second is that you can see here, it's represented schematically, but there's structural gaps in the pia mater. And again, that's to admit the passage, the easy passage, particularly of fluid, from choroidal capillaries to the secretory choroid epithelium, and ultimately into this blue space, which is the CSF. So make sure you have a good understanding of what is happening here. So the arachnoid cells are in blue, right? The subarachnoid space containing the cerebral capillaries is here, and to create the choroid plexus, these loops of capillaries deep into the ventricles to form choroidal capillaries. And that combination structure is the choroid plexus. So cerebrospinal fluid, when it's produced by choroid plexus, this is sort of the typical flow. So it's from a lateral ventricle through an interventricular foramen into the third ventricle, through the cerebral aqueduct, out through one of the foramina in the fourth ventricle, into the subarachnoid space, and ultimately, as it fills up the subarachnoid space, at some point it will pass from the subarachnoid space into a sinus through an arachnoid villus. So the arachnoid villus is a one-way valve that emits CSF from subarachnoid space to venous circulation. And so it's really important to think about the compartments here. When the CSF is in the fourth ventricle, it is contained in the ventricular system. It enters the subarachnoid space via one of the foramina, and eventually, as it fills the subarachnoid space, at some point along its journey, it will move from the subarachnoid space into this venous circulation at an arachnoid villus. Okay, so keeping those compartments in your head. Neuroanatomy humor. Okay. And I've said that before. You have to note that the central canal of the spinal cord is continuous with the ventricular system, while the foramina caudal to the fourth ventricle, or at the base of the fourth ventricle, empty into the subarachnoid space. Yes. And this is sort of the word version, schematized version of all of those. And so it will, from the site of formation in the choroid plexus, typically in a lateral ventricle, although it could be produced in the fourth ventricle, all the way down to filling the subarachnoid space. And the subarachnoid space is, of course, finite, right? So although it's moved with gravity, it will eventually get pushed superiorly and absorbed into the venous circulation. Now, we've talked a little bit about this. So the subarachnoid space widens anatomically in a few places, and this forms larger CSF collections called cisterns. So one of the most important is the lumbar cistern. This is where CSF is collected for lumbar puncture, and you can measure opening pressure at the lumbar cistern and collect fluid diagnostically to check for the presence of bacteria or cancer or blood in the CSF. There's other cisterns as well. For example, there's the prepontine cistern anterior to the pons, and the cisterna magna, which is probably the most commonly referred to cistern, which lies inferior to the cerebellum. And now the arachnoid villi, as I've already said, are the major sites of resorption, or reabsorption, or absorption, I don't know about all those terms, of CSF. So this is where CSF passes from the subarachnoid space to the sinuses. And here we're looking into the floor of the superior sagittal sinus, so in the roof of the skull. And you can see that in this specimen, you can see both the arachnoid granulations and cut cerebral veins. So venous blood is draining in here, and CSF is squirting out from these, from the subarachnoid space. Now, CSF is produced continuously. There's something I missed on the slide, actually, about how much we make. There it is. Failing. So we normally have about 200 milliliters of CSF in us. And so only about 25 milliliters of that at any given time is contained in the ventricular system. The remainder is filling the subarachnoid space. You could make it, you do make it, at about 20 milliliters an hour or half liter a day. So you're turning over your CSF continuously. So it's continuously being produced and reabsorbed. If you have, one of the consequences of a lumbar puncture, if they take quite a lot of CSF out, is you can develop a pretty bad headache. And that headache will resolve within hours or less than a day, typically, as CSF is produced. Back to where we were. Here we are. Now, when we think about hydrocephalus, we normally think about this one, non-communicating hydrocephalus. And this is pretty intuitive. So if a portion of the ventricular system is blocked, fluid builds up proximal to the obstruction, or rostral to the obstruction. And so the ventricular system will expand, compromising brain function, where proximal to that obstruction. The more common type of hydrocephalus, particularly in adults, is actually this one, which is communicating hydrocephalus, where there is no physical obstruction. It's caused by actually impaired reabsorption, or less commonly by excess production. So some sort of imbalance. A subtype of this is normal pressure hydrocephalus. So normal pressure hydrocephalus is technically exactly what it sounds like, right? So there's no increase in intraventricular pressure. It's swelling of the ventricles due to chronic ventricular enlargement and aging that we've already talked about for the lateral ventricles. So normal pressure hydrocephalus is a confusing term because if there's normal pressure-wise, there's a problem. So we're not going to use that. We're going to use communicating versus non-communicating. Now, obviously there's a huge spectrum in symptoms here, varying by what division of the ventricular system is enlarged, and so what's squishing adjacent to it, and how big it gets. And the onset is, and when I used the word onset in the quiz the other day, somebody asked me what onset meant. So onset is temporal. So when is the onset of symptoms? So it refers to symptoms that arise slowly due to chronic illness or acutely due to an event that's sudden, like a stroke. So in this case, there could be a sudden lodge in a portion of the ventricular system, and onset would be relatively sudden as fluid built up proximal to that obstruction, although not as sudden as something like a stroke. And the onset can also be chronic. And so if there's a really slow, insidious progression of hydrocephalus, perhaps due to impaired reabsorption in communicating hydrocephalus, then the brain will compensate for quite a long time, and eventually symptoms will develop. So that's what onset means. It's a time course of appearance of symptoms and signs. Now here we have I can't say this word, oh boy, ependymoma. That was fun. And so now Pandemonium is a tumor of the choroid plexus, and it is one cause of non-communicating or obstructive hydrocephalus. So this is a common cause in children. And as you can see here, this 2-year-old has a tumor in her 4th ventricle, and the other divisions of our ventricular system are labeled. So in these are CT images. The areas of CSF accumulation appear dark, so there's no contrast agent used here. The CSF is relatively hypodense and dark. And I'm just going to ask you a few questions about this. So first of all, what imaging modality is this? I've already sort of given it away. What type of anatomical plane? You should readily know. And a third question, which is hopefully a little bit harder, which image is superior and how do you know? And so I will leave you with those 3 questions for the end of this little lecture.